dietro e i laser.
Okay. I'll try to be concise if it's possible. Thank you very much for the invitation and to talk to you about the surgical vision about Mitraclip and surgery. This is not my presentation, I guess. Can I have my presentation? Maybe now? It's always difficult to speak after two brilliant cardiologists and who focused very well what is the issue with Mitraclip, saying that, as a matter of fact, there is quite a good indication now for the Mitraclip use. Oh, right, here we are. So, as a matter of fact, cardiac surgeons are dealing with surgical treatment of mitral insufficiency in the last, let's say, 30 to 40 years. And we learned a couple of things which are, I think, rather important. First of all, we have three elements we have to be considered. The first is the patient, his risk profile, his biological profile. Then we have the disease, which is the underlying disease, which is very important to decide what kind of procedure to perform. And how did the disease affect the valve is also important. And also the doctor should actually act deciding which is the risk-benefit in the procedure for the patient. We learned that in dealing with mitral valve insufficiency, we have to consider there are valvular elements and there are also ventricular elements. So as a matter of fact, the function of the mitral valve depends on the interaction of these two very important elements. And as the cardiologist already mentioned, Carpentier was the first to identify this combination and actually introduce this in the cardiac surgical treatment of the mitral insufficiency. And he pointed out the problem of the dysfunction, lesion, and etiology, and then put up a schema which is rather interesting because it has important consequences in the treatment. As we can see here, then we have primary or organic disease, which is the first three categories of Carpentier classification, and secondary or functional disease, which is the type 3 of the Carpentier classification. If we deal with primary mitral valve regurgitation, then we know that surgery is very effective. As we can see in this work, this paper of 2009, then a 10-year overall survival in a symptomatic patient with severe mitral regurgitation, submitted to early repair, compared to similar patient treated conservatively, is very impressive. So we have 86% survival versus 24%. If what we have learned in this long years of studying the pathology of mitral valve from the surgical point of view, then we pointed out that we have to reconstruct the valve. Then we have some goals which are important in some elements. The elements are the area, the shape, the leaflets, the perspective, and the structure. And the goal is the orifice area should be 2/3 of the leaflet surface area. The shape should be, there is a ratio between the transverse and the anteroposterior diameter, long coaptation area, and a long-lasting result, which we want to achieve. And of course, we have to decide also what is the quality of the tissue that we are dealing with. This is an exquisite surgical decision which has to be performed during the operation. As far as the elements are addressed, then we have developed a lot of techniques which have been implemented, the leaflets, dealing with the leaflets with quadrangular resections or triangular resection, addressing the annulus. So we developed the stabilization of the annulus, which is very important issue, and then also trying to influence the height and the coaptation level of the chorda. And eventually, in some cases, also the Alfieri stitch, the edge-to-edge repair, has been introduced with some success. If we look at the results of this technique, then we can see that we have brilliant results. We have some results in recent series with a lot of patients, and you see that hospital mortality has been consistently low. Of course, this refers to a mixed population, and of course, there are also in this collective also many patients who are young. If we look at the time frame, the long time result, then we see that also these results are very good. We have up to 90% reoperation freedom of 15 years in a recent series of McLeod, but we have also 90% in 10 years, 97%, and so on. And some of these results have been achieved with mini thoracotomy, so I think that the surgical technique also improved consistently. These successes have been, of course, considered in the guidelines, so we can see that, as a matter of fact, most of the indications are in class 1. Now we have learned also that there are some very important issues that have to be considered in order to define the decision to operate. Mitral valve regurgitation severity is important, LA dilatation is important, BNP elevation is important, and all these data point out that probably the best thing to do is an early reconstruction. What we have learned in the last 30 years, first of all, mitral regurgitation is a soft killer. So if you don't do anything, then probably when you decide to operate, it's too late, and the results are not so good. Operation is necessary. The repair is much better than replace, and we should address all the valve elements, and annuloplasty must be added. We found out that annuloplasty is a very important issue. Early repair leads to a low morbidity and long-lasting results. And mini thoracotomy approach seems to be valid. So, but you want more. The secondary mitral valve regurgitation is a different issue. If we look at the pathology, the physiopathology issues that are concerned in the secondary valve regurgitation, that we have mitral regurgitation, which is due usually to ischemic cardiomyopathy, leads to papillary muscle displacement and annular enlargement. And mitral regurgitation leads to ventricular dilatation and increased wall stress. And LA enlargement, atrial fibrillation, pulmonary hypertension, tricuspid regurgitation, and ventricular dysynchrony. So what we can do in this case is, as a matter of fact, is very little. So we can perform aortic coronary bypass surgery if it's indicated. We can remodulate the left ventricle. We can, of course, perform some surgery to the mitral valve, and we also can consider the implantation of an ICD. But as a matter of fact, we know that the results, the surgical results in mitral regurgitation are not that good as we thought they could be. So the most common operation that we perform is usually a restrictive annuloplasty in these cases. And we have some results here which has been pointed out that there is almost 1/3 of the patient develops a grade 3 to 4 mitral regurgitation 1 year after the operation. So these kind of results are not as good as we would like to have. The influence of there are some patients, though, that they can somehow be a good candidate for this kind of surgery, and they have the results which are lasting longer than we expect. And probably something that is similar if we then consider the Mitraclip afterwards. In other words, the population is not homogeneous, but we don't know exactly which patient and why responds favorably to this kind of operation and other patients do not, and keep increasing their ventricular volume and also the mitral regurgitation. So, surgical result in functional mitral insufficiency is a ventricular problem, mostly due to loss of contractile mass, poor prognostic indicator, dismal natural course. A long-lasting result are rare to achieve, and the primary aim is to temporarily improve the symptoms and reduce the hospitalization. And there is a limited efficacy of other solution for ventricular problem. This is the main problem. And so we usually suggest restrictive mitral valve annuloplasty with or without bypass surgery. So the cardiologist said at one point, let's do better. And so they introduced the mitral clip. I don't go into the details because we know already from the previous presentation. But one thing that probably they forgot is that there is a return of mitral regurgitation, the grade 2, 3, and 4 over time in patients which have been operated by leaflet surgery without inserting an annuloplasty. And the problem is that you have 33% in this recent study in which there is return of mitral insufficiency. If we look at the worldwide experience using the Mitraclip, at least these are data from the end of October 2012, and now we know that this number rise to 10,000. And the rationale to use Mitraclip is actually based on 279 patients in the EVEREST protocol. So I think there is some wide use of commercial patients, these are data for Abbott, that probably are not exactly in frame with the real indication. So what we know is that the first data on EVEREST 2 trial was that there was no big difference between the two technique, I mean the device group and the control group, which is mainly surgery. And as a matter of fact, this is the view of the cardiologist in which the 2+ mitral insufficiency is considered not so bad, and this is probably the way the surgeon would look at this data, and this is quite different. After 4 years now, we found out that the results of the Mitraclip are not as good as we thought they could be, and we probably, as surgeons, anticipated this data. And this data come from this is pretty recent, the 7th of May in 2013. And what we can see is that at the time, the mitral valve surgery or reoperation was necessary in 25% of the patients. So as a matter of fact, these data say that there is something that is lacking in order for the mitral clip to achieve good results, and probably is the lack of annuloplasty. But anyway, the mitral clip is so far as an ingenious technique for a less ideal indication in degenerative mitral regurgitation unless the patient has a prohibitive high surgical risk. Functional mitral regurgitation could be probably a better goal, and I agree completely with the cardiologist who just said that there is a very special indication for the use of Mitraclip. Continuous research would open new perspective, and there are a couple of studies going on now dealing with the functional mitral insufficiency, and some experimental work trying to introduce the possibility of insert mitral annulus, an annuloplasty through the catheter, and everybody knows this about Valtech Cardioband technique. So, short bottom line consideration. I skip this because it's been taught before, but I think that we have to, in order to compare two kinds of techniques, then we have to see that the paradigms are the same. So we have old paradigms, plate-driven, address all components, residual mitral regurgitation is bad, fix it forever. If we look at the new technology, it's catheter-driven, address one component, the residual mitral regurgitation is considered to be okay, and we fix it for now. So we should, of course, avoid programmed obsolescence, which is small nowadays, and avoid also the hammer-nail syndrome. So another point is asymmetry. I don't refer to what our previous colleague said, but I think the real world looks a little different. So we have, as a matter of fact, the cardiology team and we have the surgeon team, but the referee is usually a cardiologist. And this is probably something that we have to work on. The natural history of Mitraclip, used for all the primary mitral insufficiency, looks like a natural history of a new treatment. Every new treatment has this kind of curve. And you see, if we point out, then it's probably will look like something like that. So I think that Mitraclip will have a place in the treatment of mitral regurgitation, but the effort of surgeons and cardiologists should be to define exactly which is the area in which the patient will benefit the most from this kind of therapy. We should also go beyond the score system that we have nowadays, which is, I think, do not reflect exactly the real risk of the patient, and I think that patient biology should be addressed much better, and I think that the different tools that we have, they have, of course, different indication, and not all the patients are considered to be Rothko, not always a Klee, and some of them can be a Chagall. So, for the next generation, we may have all come on different ships, but we're in the same boat now. This is, I think, applies very well to cardiac surgeon and cardiologist at this time. Thank you very much for your attention.